Hi, welcome everybody. Welcome to this session on matching technology to the right need, AI and the art of possible. My name is Harris Schwabe, and I am Head of Clinical Scientific Computing at Guy's St Thomas's. I'm also the AI Transformation Lead for the London AI Centre. And on our panel today, I'm joined by Tony Newman-Sanders, who is Chief of Cancer and Diagnostic Services and CCIO at Surrey and Sussex. I'm also joined by Paul Wyman, who's RPA Architect in Dorset. Pete Buckle is Principal Research Fellow in Human Factors at Imperial College London, and Patrick Shepherd, who's Head of Healthcare at Blue Prism Cloud. So welcome, everyone. This is HETT Reset, resetting, it's supposed to be after the pandemic, we're still in the middle of it. And what I wanted to start off with is trying to understand from people's personal experiences in their professional work, where they think or where they've heard of AI having a positive impact in helping us deal with the pandemic, and where they think it missed the mark and could have done something better. Tony, let's kick off with you. You're a consultant radiologist. How has it impacted your work?
Yes, and I also do a bit of work on diagnostics for the Southeast region, so was heavily involved with when everything became a COVID cell. And I guess the most obvious way that AI came in is that companies who'd been, and we'll come to this later, I suspect, in the discussion, that companies who had been making the case for their really quite, in many respects, admirable products to get traction within NHS frontline practice, took a little bit of an opportunity to say, because we're all on a war footing and anything that could help with the pandemic was being funded, to offer their products as part of the war effort, I guess. So it's a little bit, scrap metal for victory. An example would be, some very good AI products to help us all in the diagnosis of stroke on CT scans. Suddenly found that they were able to jump through hoops, if you like, or overcome hurdles that had been set up between them and actually then being sort of trialed and put into practice in frontline healthcare, which is a good thing, not necessarily directly related to COVID, but under the pretext that it would help us all to do our work better and therefore concentrate on COVID and help with things like challenges to the workforce as people fell sick. And there are a number of things like that. But basically, a lot of AI products in radiology have, I think, taken several steps forward in terms of route to market because of the pandemic. In terms of what's actually helped with the pandemic, it's been more of the softer stuff. Remote working, a lot of other technological things like remote working, which may be partly helped by AI. But a lot of that stuff ended up front and center of the actual real sort of a successful attempt to deal with the pandemic.
Pete, what's been your, estimation and evaluation of the kind of solutions you've seen come to market? You have lots of experience in diagnostic testing in general. How much value do you think they've actually provided us in detecting coronavirus in the community?
Okay, thanks. Well, it's been a fascinating journey the last 9 months, and I think it's been characterized by a couple of things, I think. And whilst as an in vitro diagnostic group, we've often seen AI applications come to us for other conditions, we haven't seen so much around COVID diagnostics. I think that's partly because there's been a massive rush to bring other products to market for diagnostic testing. And I think a little bit like Tony was just saying, we've seen some extraordinary changes in how these things can be done. So we were part of a group at Imperial that got together with 5 other centres nationally, put together a really robust evaluation framework, which hasn't existed before, to really rapidly assess the validity and utility of diagnostic tests. And just to illustrate, we're working on an AI application at the moment for melanoma, which is probably going to take about 2 to 3 years to evaluate properly. With some of these diagnostic tests, we're doing them in 2 to 3 weeks, in some cases a few days, just to get a feel. Now, I think the learning point there will be that actually AI applications in future, if they work through a system like that, we're in a position to take them from concept to hopefully delivery in a much, much shorter timescale across the country. So I haven't actually seen a specific AI application for diagnostics come down our pipeline, as it were, but I've seen an awful lot else in terms of diagnostic tests. So maybe that's helpful, and we can bring that up later on in the discussion as well.
Thank you, Pete. And yeah, definitely, we'd love to hear more about the evaluation framework. Paul, RPA, I guess, is almost a sister technology to AI. What impact has that had, particularly, I guess, in Dorset?
So the first situation we came across with using RPA to help out with COVID would be with the antibody testing. As you know, the antibody testing came out, we were given, I think, 7 days to prepare the ground, get people booked in, tests applied and whatever. And when we looked at the sort of manpower required for staff, I think we looked at about 22 members of staff were going to be required just for a sort of 8-week testing program. Given 7 days notice, we got the Blue Prism Cloud set up, and actually after 5 days completed a full automation for booking people in, processing the test results, uploading as required, and it worked really well. There was a few teething problems, and over the first 4 weeks or so, we tuned the whole environment, and it worked really well. And I think that was probably the big win. I think we worked out roughly it was going to cost about £40,000. That's what we saved using the Blue Prism product, which is a great advert for them. So there you go, Patrick.
You're welcome. So Patrick, so I guess you would have seen perhaps how different trusts have responded with RPA across the country, right, through your customers. And Paul just explained that, how, in a rapid fashion, with 7 days, you said you had something deployed to help you with antibody testing. Did you see that same success across the country? And then also, what is there that you wish trust would have done in addition to that you feel would have helped as well?
Yeah, so Paul, thanks very much for the plug, by the way, much appreciated. So I think the first thing I would say, I guess, to go back slightly to the original question around the AI bit, Harris, is that I think what we found was that there was an inherent difficulty that for any decision requirement when it came to COVID, that it was almost guaranteed that you could solve 60% of that requirement using fixed rules, right? So you could almost look at some of the problems and some of the automations that people were looking at and apply logic. And the challenge actually was that there weren't enough people to administer that logic to meet demand, because all of a sudden they were being asked to conduct daily COVID sit-rep reports by 11 a.m. every day to NHS England. They were being asked to submit swab data. If you look at Kettering Hospital, just that COVID daily sit-rep report, by automating that process, they'll have saved 4,500 hours of management time just uploading data. And I think what we've started to see is an evolution of that, because if you imagine that most trusts are absolutely inundated with work, and right now we're going through a COVID, obviously the vaccination program. I've spoken to a number of trusts today and this week, and I know it's something that Paul's looking at, but just uploading data of the vaccination that were administered up to NIVS, obviously the National Immunisation Vaccine System, that 20, 30 people per trust are being asked to upload that data. So if you imagine that they've got those people being asked to move information from one system to another, and there's 800 or 900 of those to do every day, then that becomes a real problem for most trusts. So I think having software robotics that can start to take up a lot of that slack so that human beings can use their cognitive functions, that's what we've got. We've got empathy and compassion and verbal reasoning. If you can start to free people up to spend time doing that and spending time with patients, then actually there's a massive benefit to the NHS. And to your other question around what could they have done more, I think that's a really tough question. I think what we've tried to do is realise that some of these challenges are universal. So, this process I've just talked about around updating NIVS, that's something that Paul will be facing, that King's will be facing, that Imperial will be facing. All of these acute trusts will be facing that same problem. So how do we start to regionalise or productise some of these solutions at an ICS level or a national level, And actually, there's been some great work done by NHSX to start to, productize some of these solutions for national benefit. But yeah, I mean, the COVID daily sit rep report, the stuff that we're building out now, anyone that engages with us and our platform, they can absolutely have and share with the NHS, and hopefully that brings quite a benefit. But it's been a very busy period for us, as you can probably imagine, and I imagine that's going to continue for the foreseeable.
Fantastic. I mean, so reflecting on all those responses, what I hear is that, and what was my experience as well at Guy's Autonomous is that the stuff that delivered real value to us, that was immediately helpful, was some of the traditional digital transformation stuff. Things like Microsoft Teams being available and installed, and everyone sort of switching to remote communication and having remote access to the trust system, and then also some of the RPA work that you've mentioned around automated uploading and reporting and things like that, and all of that being done in very quick fashion. And then I think about my day-to-day work in trying to develop and deploy AI, and it sounds a lot like when people are describing 2 to 3 year evaluations, right? Before we feel confident enough to deploy this stuff. So why is it that sort of contrasting picture? Tony, are we tackling the wrong challenges, or is there something else about AI that means that we can't do the 7-day deployments?
Yeah, big question. I mean, I was just going to come back to it. It's not strictly fair. I just was reminded of one of the algorithms which came up fairly early in the pandemic, which is essentially a pattern recognition algorithm to help us diagnose the CT patterns of COVID infection. At the beginning of the pandemic, that was all quite new to us, so we all thought this was quite interesting. And but 3 weeks in, we knew it like the back of our hands. We kind of hardly saw anything else. So, and actually, what we were then interested in was the emerging, pattern recognition of the bowel complications or the brain complications. So, I guess from the pandemic point of view, it makes the point that the problem statement was pretty fluid from the point of view of diagnostics, and it would have been a big ask for anyone to kind of deal with a holistic product that would have still been useful to us at the end of the pandemic. In terms of your question, I think that there's clearly a deep-rooted emotional, an iRobot fueled sort of anxiety about AI, which means that otherwise sensible, brave people feel sort of unable to proceed as quickly with stuff which is seen to be less kind of, I don't know, Orwellian. There's certainly, I've sort of found, whether it's working as a national clinical director or with local sort of trust procurements, that as soon as you start bringing in systems which have the potential to become accountable for clinical decisions, then people just don't know how to deal with it. And frankly, I think the regulators and CQC are also still kind of working out how to support us in this. And so the kind of the default level is that everything sort of stays or is designed to stay pretty much at advanced clinical decision support. So it's sort of helping. I mean, I'll leave aside the RPA bit, which I think is a huge undertapped area. But I mean, Patrick's, I think, spoken very eloquently. But in terms of what we may call traditional deep learning, it remains the case that there seems to be an anxiety about really taking the plunge and trying out stuff which could end up in court. That you could end up, the algorithm having to explain itself in the coroner's court. People just don't know how to deal with that, and so we effectively end up with a different problem statement, which is what can we do to help the clinicians be more effective, and frankly, that's often the right set question to ask. And I think that in many respects, the products that have helped us answer those questions have helped a lot. And so you then, something else comes along, which would be a genuine game changer, the genuine kind of self-driving car of medicine. And suddenly everyone from the regulator down to the local ethics committee sort of stop and think and put it in the too difficult box, and it all starts again.
The interesting contrast in these workflows is that, I mean, for example, we have Paul on the call, who's an RPA architect, right, who works for the NHS. We don't have AI architects, right? And hearing about the problem, Tony, that you outlined, that the problem set was very fluid, right, at the beginning when it come to, which problems can AI help us with. And so it required that short feedback loop, right, where you're working, very much in tandem with the people who are developing or deploying this technology. Paul, can you tell us the advantages of having someone like yourself who is essentially exploiting the technology for the local use case and making sure that it's delivering local value? And what lessons can AI companies and organizations that want to deploy AI can take away from that?
I think one of the main things, first of all, with AI is a very big umbrella. And with a lot of the diagnostic stuff that Tony and Pete are talking about, you're on about deep learning. So you've got huge amounts of data which are needing to be processed, and that's going to slow you down because you've got to go through the machine learning process, deep learning. Whereas with RPA, this is a symbolic learning process. So we've got everything ready to go. So I can quickly turn something around. And the advantage of having somebody on site, as it were, in the Dorset ICS is I know how the technology works, and when somebody comes to me with a problem, we can look at fixing it. And I know Tony was talking earlier about having people having a solution and then looking for a problem to fix it. I mean, we've discussed that many a times in IT. But certainly with myself being there, people can come to me, and on a daily basis, I'll have people say, how can we automate the following process? And I can just jump straight in, and we can look at getting a plan set up and fixing it.
Do we think, and perhaps this is more pointed at Pete, that especially with your experience around evaluating or testing the validity and effectiveness of some of these technologies, can we break down this sort of waterfall method that we seem to be engaging with AI technologies, where we sort of look for what's on the market, then we test it, and then we tell them that this is no use to us? Can we turn that into a more agile framework where we are part of the development and evaluation lifecycle before anything even reaches the market? Is that even possible?
I think it is possible. I don't think it happens very often. So I'm totally excited by the idea that we should do that more often. I do think that once we engage with AI companies, or whoever it might be, innovators, in the right way, they rapidly come to see that is the approach to take. So typically what we would do is we would think about what the problem is that this AI is hoping to address within a very complex system, talk with all the key stakeholders. So it could be we might often start with the consultants and then end up actually finding that this thing has got a much better home somewhere in primary care, for example. And then we start to work with the developers to think, well, how would this impact across a care pathway or something like that? How will it change the way that we manage a patient? Because ultimately, that's what most, certainly in the area that I'm in, diagnostic is about. The curious thing I think we've found with the AI applications that we've looked at is that where they're potentially most useful is in that very zone where the clinicians have most doubt. So it's where we're not sure. And that is a really tricky area to explore without really understanding, as we would say, work as done, really trying to understand how clinicians make decisions in those situations. Because otherwise you end up, as we've found quite often, with an application that's quite good at spotting, as it were, the easy things, the no's and yeses, but it's that middle area that is the really tricky areas. So really working in a development phase around that is what I would say is the sweet spot. And I think we can do much better in that zone, to be honest with you, Harris.
I wondered, Tony, what your thoughts are around whether we should have tackled this. I mean, we did try and tackle this to a certain degree at a national level. So NHSX set up a national database for imaging. And I believe it was hosted at Royal Surrey, and they tried to get trust to contribute imaging data for patients as well as associated clinical data to try and deal with the issue that Paul pointed out. You know, the thing with AI and deep learning is that you need lots of good quality data. And you've got experience of national programs with the National Program for IT being NCD for diagnostics. How do you think that panned out? Do you think that was the right approach?
Mute.
Oh, sorry, can't hear you, Tony. I think you're on mute.
and interrupt. I do beg your pardon. I think the national programme, I happen to work for a bit of the national programme, which by common consent generally succeeded, but partly because it was it was based on a 10-year-old imaging standard called DICOM. So we were well ahead of the pack, and it's also a product which is pretty well developed and people wanted. So it wasn't any great merit on our part. But one of the things that by the end of the national programme, everyone was saying we're never doing this again. So anything with the words national and IT and data still raises antibodies at levels, and I think that's probably right. I will come back to that. I think Pete made a really important point about the grey area, and there's something about my limited experience in terms of AI that one of the things that AI can do is in making the yeses and nos a lot easier, or at least you can spend less time on them. Is there a lung nodule? Is there a fracture, etc. Then it does physically free up time and bandwidth to actually deal with the grey areas. So I don't think they're mutually incompatible. You then, to a certain extent, you could then say that the diagnostic professional, if he's got more time on the grey area, then in terms of teaching the AI how that works, to a certain extent, we've got more bandwidth to do that in terms of, and the segue into your question about national databases is there's certainly a kind of a sense that if only we could give the AI companies enough red meat to chew through, then they would kind of be able to simulate what we do. And that may be true, but I think there's something about we still have to articulate the problem statement. And if I can give if we had 10 million CT abdomens and a radiologist who could label it up, then you may then get a CT scanner that could kind of increasingly through deep learning predict some pathologies. But I think it would not take us very far down the road of actually getting them to make the difficult decisions that we do. I mean, clearly at some point it would, but I think that the business of AI in imaging certainly as just being a question of getting enough labeled data and giving the algorithms a chance to chunk through it. I'd actually go back to Pete and say, how much do you think that would achieve? Because I still think we'd get left with what are the actual problems that you need to solve, given that I'm starting from the premise that I think everything I've seen means that a computer that can actually do what I do in my entirety is still some way off. Do we hold out for that, or do we kind of go for the lower hanging fruit in terms of ruling out stuff? So the chest algorithm that will actually with 50%, with 90% negative predictive value, tell me this chest X-ray is normal, rather than spending a lot of time teaching it to diagnose an esoteric rib tumor. Yeah. Obviously, either of those things, a big database and a big effort to kind of label it and work with the AI companies would be a good thing. But even if it would, we then left with who would curate that? Who would have the authority and the nerve, frankly, to sign a contract that big and sign off the data sharing agreement and deal with the Daily Mail and everyone else who'd come out of the woodwork to say, what the hell are you doing with my data? Google try and do something relatively innocuous at Royal Free, get on kidney detecting renal failure. The data sharing agreement isn't quite right, and the Daily Mail's all over it. People are losing their jobs, and there's a lot. Everyone in the system has been around long enough, and you might have the seniority to kind of make those big calls with big AI companies. It's still petrified of that stuff.
So where do we go from there?
I think it has to be smaller. I've seen no evidence that there's any appetite, even amongst the Simon Eccleses and Matthew Goulds of this world, to grab that sort of thorn bush and get your arms around it.
Sorry, Patrick, were you going to say something?
Yeah, no, I was just going to. I think Tony's absolutely right. I think AI is highly situationally specific. It's specific to one thing, and that's got many consequences. So, first of all, it's no good making a single, £25 million platform based investment in the NHS for something to do everything AI. That doesn't exist. That combined with the pace of change, I think the NHS has to accept that the chosen solution right now may well be obsolete within a very short space of time. Right? If we were looking at driverless cars 10 years ago, we definitely wouldn't have been betting on we'd been betting on a Ford rather than something different right now. So I think there's almost that that short-termism thing, especially with AI, isn't potentially bad, but also you almost need this multi-vendor approach with short time to value and a high turnover of projects and technology choices in order to get to that point. But I think the biggest thing is probably a culture and staffing structure to accommodate this type of flexibility. Because if you're trying something, with a multitude of different vendors to try and get the outcome that you desire, you definitely need the structure in place to make sure that works first. So, it might be a very basic observation, but frequently overlooked in people's excitement to investigate AI is that you need a digital business first. There's no point looking at AI, a paper-based process or system, or where you need, 50, 60 people to trawl through letters and start opening them to then deliver an outcome. So I think Tony's absolutely right. And I wouldn't hedge my money on somebody putting their foot forward first and saying, right, we're going to go for it, because, it's inherently risky to do that. So I completely agree with that.
Harris, there's a very important voice that isn't actually on the call at the moment, but is that the whole purpose of this is really the patient and the public involvement and engagement voice. And I think what we have learnt with our work at Imperial College with the in vitro diagnostic group is we work with our patient public involvement team from the very beginning of everything, and they are part of it all the way through. Because albeit that you might end up with an algorithm which actually on paper does what it likes, does what it wants, what the clinicians want it to do, is it trusted? Is it trusted by the patients, by the public, and so on? Is extremely important. And I think we have a major challenge in this area of trying to help everybody understand what algorithms and what AI is really doing and what it is not doing. And I think our experience has shown that where it is helping decisions to be made, but the responsibility is still lying with the healthcare professional, it's more accepted than were it to be something that was making a decision without that input. So I think understanding how patients and public and healthcare professionals and others are going to work with this and are going to trust it has to be an integral part of the design, the whole process from the beginning. And that, unfortunately, has been missed sometimes with potentially disastrous consequences, I think, for the long-term future of the industry.
That's such an important point, Harris. Obviously, anyone who's ever worked at a national level, we try and get patients involved. But if there's an area where it's really difficult to get the right kind of patient involvement, it's this. Yeah. Because having a mixture of someone, you almost need the kind of tech naive person who kind of just gets what is being done to me, but at the same time, someone who kind of understands a little bit. And I think if Pete and his team have got that cracked, then that should be bottled. And because I agree, it's absolutely important at every level, but it's not easy.
It isn't easy, but if you don't do it, it isn't going anywhere, I'm afraid.
No, I absolutely agree.
I echo both of those points, especially when we think about some of the ambitious stuff around national databases and really large-scale, say, for example, federated learning, right, where you're learning on data across a network where the data doesn't actually move, but you just move models around. The way we explain this to patients becomes tricky, and I don't think we've set the groundwork in terms of doing a good job, and it's going to become a serious problem and a barrier to achieving some of the things that could be achieved. The other point I wanted to make was around trust and culture. So a report came out earlier this week around the MRAD trial of the mammography AI, so in the Midlands, and there was a bit about trust and confidence, and there was a higher level of confidence from the patients in that scenario. Then from the clinicians, I think there was only just over 50% of clinicians who said they either agreed or strongly agreed that they were happy or trusted the AI. I might be misquoting it. And I think part of this is about engagement, right? So we've talked about public engagement, and we know that's so important around, trust and consent for some of this stuff. But when it comes to having technology that we trust to use as clinicians, and ones that we believe are effective, and it goes back again to that why statement and the problem statement. What should trust be doing to have better company or industry engagement, right? Because at the moment, from my perspective, the industry engagement looks a lot like what poor patient engagement is, in that it's sort of at the beginning and at the end. And it's almost just sort of the minimum viable amount of working with the industry. Does that need to change, and how do we change that? Tony,
if I kick, so I mean, obviously the academic health science networks were set up in large part to address that problem, that the NHS as a construct of the post-war Labour government has a kind of historic, if maybe not entirely fair, reputation as being a very bad customer for industry and being very anxious about commercials. And so I have to say that although the model of the AHSN to do this, in London, we were among the AHSN network, we were kind of given the lead on tech. And in fact, the Kent-Surrey-Sussex network, which I work in at the moment, is actually on the lead for AI. And they certainly do a good job in terms of putting that, building relationships with tech companies, particularly the local ones, and with universities and research departments. But it's still a challenge. And I found that when I was a medical director of an AHSN, then going and talking to trusts, that actually carrying that into trusts and procurement, even if you can get a medical director on side or a chief exec, then getting through the kind of procurement hurdles, dare I say it, some of the commissioning hurdles as well, it just seemed like really hard work. So I think that we're getting better at working with industry. I think given the AHSNs are there, my preference would be, and given that we've got kind of legislation coming to empower integrated care systems, that the energy should be in that direction. Obviously, trusts remain sovereign entities and commission CCGs remain sovereign entities, but I think building up the relationship and the culture at kind of regional ICS and academic health science network level, and really starting to break down the barriers about perhaps risky deals with industry would be a good first step.
Patrick, what are your thoughts around NHS being better customers?
You know what? I think Tony's hit the nail on the head. We've been doing an awful lot of work with AHSNs. I think they've been invaluable for us to start spreading the message. I think it's easier. We work with 53 trusts up and down the country, so it's likely that we're engaged with one particular area. I mean, I was going to ask a question more back to Tony on that, if that's okay. Is when we're trying to justify a business case that says we save 22,000 hours a year because actually we've automated a number of processes and therefore there's better patient care because staff are spending more time with patients, et cetera, et cetera. The argument that comes back is, well, how are we going to save that money? How do we justify the return on investment? And in the private sector, it's easy. They'll say, we will remove that headcount. And that doesn't tend to happen in the NHS and for obvious reasons. When it comes to AI, how do you justify a business case to then get those things off the ground to a fairly legacy, I don't mean that rudely, but a sector that's not potentially looking forward all the time at the latest and greatest? How do you start to talk about that as a business case into the NHS, do you think?
Well, if you take a very specific example, which is live at the moment because of diagnostics and the Richards Review, and the move to effectively saying a lot, as Lord Carter determined for pathology some years ago, that the diagnostics should be done through large technically optimized networks. And it's explicit in that these are going to be the minimum size units for doing serious deals with AI companies and complex technology. And that's absolutely right. And ultimately, until you get to a stage where only diagnostics will only be commissioned, and if you're not in a network, you don't get to provide diagnostic services. At that point, everyone's minds get focused. And if you take the imaging thing, it's a kind of recurrent cheat that the NHS does. But rather than taking head count out, we'll say, well, actually, we know we haven't got enough radiologists. So rather than actually making a bid to Treasury for 500 new radiologists, if you give us some AI which helps us to work efficiently, we'll only need 200 more, or maybe no more. We're not going to lose radiologists, at least not yet, but we are going to moderate the NHS's desire to just throw money on sort of existing, often quite sort of not particularly efficient systems. And so when people say to me, well, the imaging networks is not the solution, we need more radiologists, I say that may be true, but no one can tell me that just throwing more radiologists at the existing system is the right thing to do. And at least if we've got networks set up which are optimized technologically, both low level and AI level tech, then you can make a better case for actually throwing more warm human beings at it.
If I could just add to that, certainly at Imperial, when we are looking to work with any industry or anyone that comes with any innovator with a new diagnostic, we immediately also put our team of health economists onto it to try and understand what the value proposition around this is. Because that links, as Tony was saying, we've had many examples of what look like smart imaging applications, but actually it would then require 1,000 more endoscopists in the health service. So it's not going to happen. But actually, if we hadn't done the proper evaluation of it from a value proposition perspective as well, it really wasn't going to fly, and it certainly wouldn't have made any impact at NICE later on when people are thinking about commissioning it. So it's the same thing, really. You know, if you get in early and you're thinking about the impact of your innovation, and if you're thinking about working with those that already have a lot of knowledge about constructing the model that will go alongside, is it any good? Is it valuable? That's the stage to be doing it. By the time you've reached the end of the journey, it's too late, really. You need to do it early on, but even to know where to locate it in the health service. So it's that partnership, really.
It makes me really aware. The only time I ever actually dealt with a health economist and actually appointed a couple was when I was working for an NHSN. You don't see them on the staff list of trusts or CCGs. And if you get, it's such a crucial function. You're absolutely right, Pete. That whole business of having someone who understands the commercial impact as well as the kind of the wider clinical impact of these innovations. We just don't have enough of them. And when you do find them, they often struggle to work with the NHS.
Yeah, and it's true that we've had to train ours in a certain way to look at value propositions around diagnostics, because it's so different to looking at other kind of areas of health economics, therapies, and so on.
I just wanted to wrap this up, because we're coming to an end, with sort of one final small question. There was a really good paper in the BMJ, I think last year, maybe the year before, around perhaps the need for clinical AI departments. And what that might look like. And we've just talked about, certain skill sets, like health economists and other people who can understand the technology and understand what value it brings and help inform or create an informed business case, right? That's based in understanding the technology in the way that, for example, Paul understands RPA. What do we think, and we'll go around in a sort of a round robin, are some of the crucial either skills or people that maybe don't typically exist or don't exist at all that you think would need to be in such a department? Paul, do you want to kick it off?
Okay. I'm just trying to think who would I pick first. At the moment, I'm looking around for staff to come and help me work on the RPA stuff. So I'm looking for people who, firstly, NHS-based. I want NHS staff that I can retrain, because it's easier to train somebody to learn RPA and natural language learning, processing and stuff like that, rather than actually take an techie expert from external, bring them into the NHS. I thought IT had a lot of acronyms. NHS has got way more than any IT system, and it's mystery for everybody. So one of the main ways we started recruiting by getting automation champions in the Dorset ICS. We set up a Microsoft team. We grouped a whole load of people together. I think we've got 82 champions across Dorset now. And it started off with giving people puzzles to solve. Are you interested in automation? Would you like to learn some more? Here's some puzzles. Can you solve them? That sort of thing.
Very interesting.
And those are the skill sets that we built up. And when we get bigger and bigger over time, we can take people from different areas and take maybe as 10%ers to start with and just get them to do a bit more automation. Certainly with the RPA products that we've been working with and the Microsoft stuff that's coming out, you're looking at citizen developers. So you're taking people who, we've got a couple of nurses who do some training, and they're developing an app to help with their, going through all of their training programs and stuff. So for me, it's I want NHS staff to learn more about how RPA, automation and AI is going to help them, and how they can then improve it, because they know the job that they need to fix.
Exactly. What about you, Pete?
It's very simple for me. You need people that understand socio-technical systems. That's what we're looking at. So you need people that are experts at pulling together the people and the technologists and not letting one voice override the other. We have a whole lot of human factors specialists that are basically trained to do that. They are absolutely key to making sure you've got clinicians, patients, technologists, all facilitated to enable their voices and their links to be made appropriately.
Patrick?
So clearly I don't work in the NHS, so it's maybe slightly more difficult for me to answer that in terms of people. But I think the one thing I would say is we need to sort of beware the sterile brain in a jar trap. So, so many projects take place in the lab, so to speak, and that is in isolation from real business processes and systems. So I think for a proof point to be truly successful, let alone useful, it needs to deliver value within the organizational fabric of people, processes, and systems. So AI brain plus the arms and the legs like a human would be to actually deliver the value. Else it's just one thing in one silo. So I think more of a joined up approach across the system, the NHS and the trust. Yeah,
definitely. Finally, Tony.
Yeah, I mean, it's a logical extension of the work we've seen with chief clinical information officers. It's been 5 years coming, but I think we've now got board level representation of clinicians who know enough about the IT to make a difference. And I think that needs to be extended, and it is a significant extension, as Pete alludes, and not only to sort of human factors, but deeper understanding of some of the computing underneath it, as well as the other stuff like RPA. So I think the CCIO sort of infrastructure is a good start, but it would need a lot of work to get AI involved.
Fantastic. So that brings our session to an end. Thank you so much to the panel for joining me. Thank you for the audience for listening, and we'll all see you later.